In 2012 alone, an estimated 3.3 million children below the age of 15 were living with HIV. While HIV in children is eliminated in many parts of the world due to successful prevention of mother-to-child transmission of HIV programs, 700 babies per day continue to be infected, with 90% occurring in sub-Saharan Africa. Despite the large attention given by the international public health community, the commitment of donors, the provision and wider access to HIV therapeutics and diagnostics, the youngest remain neglected. Without treatment, half of these children will die before they turn 2, and 80% will die before they turn 5. Today, only 1/3 get treated, far behind the treatment coverage for adults. The treatments recommended by the World Health Organization are lopinavir-based formulations for children infected with HIV. Additional ritonavir is needed to treat children also infected with tuberculosis. However, current formulations are inadapted to children and their caregivers.
I must give the medicine no matter what, because that virus is sitting there somewhere, and if I'm not going to give that medicine, the virus will come out and my baby will get sick. In the beginning, I was crying with him because I know the taste of, because I tasted myself.
At the moment, reliance on liquid formulations is difficult. It's large volumes of fluid or liquid medicines have to be taken home and stored. Often the transport to the sites and the clinics is very difficult, so logistically it's difficult. Also, spending a lot of time giving lots of medicines twice a day is more difficult.
What we really need is medication that is, first of all, palatable for the child, secondly, user-friendly for the parent, thirdly, can be stored in room temperature, and the cherry on the top would be to have 4 medications in one formulation.
Therefore, provision of adequate treatments to those children born with HIV and children also co-infected with tuberculosis are urgently needed.
The development of treatments really adapted for children is quite complex and challenging. Since 2011, with the funding from UNITAID, the French development agency AFD, the UBS Foundation and MSF, here at DNDi we have established a pediatric HIV research and development program to address the specific needs of children. This partnership involves CIPLA as industrial partner and research centers of excellence like Stellenbosch University in South Africa, MRC in the UK, Institut Necker in Paris, University of Nairobi and the US CDC.
So what we have done is give a grant to DNDi to develop new formulations for these children with powders or microcapsules or sprinkles that could be adapted and that the children would be able to take for their treatment.
This has been a very good partnership, in particular with pediatric HIV, where we are developing, along with DNDi, 2 products, which is a combination product of 4 antiretroviral drugs to be given in a convenient dosage form, particularly for children. We are calling this sprinkles. That means the drugs can be sprinkled over food and children can have it and eat it and thereby get their HIV under control. And I hope that this relationship will continue for another 10 years and we can give more products together worldwide for the betterment of society.
Our goal is to make these new fixed-dose combinations available by 2015. To develop such an innovation in a timely manner, the partnership we have implemented are crucial. HIV-infected children need the full engagement of all partners.